What if I told you that almost everything your doctor told you about testosterone replacement therapy is incomplete? I'm not talking about fringe internet claims. I'm talking about studies sitting in peer-reviewed journals that most general practitioners never read, because testosterone isn't their specialty. I'm Dr. Lina. I'm a board-certified urologist, and today I'm going to walk you through the truth about TRT, the benefits, the real risks, the things that will actually happen to your body, and the questions you must ask before you ever inject a single milligram. Stay until the end, because the last section, on what I call the exit problem, is something almost nobody talks about. And if you're already on TRT, it could change what you do tomorrow. Testosterone peaks in your late teens and early 20s. After age 30, it drops at roughly 1% per year. By age 45, a significant percentage of men have clinically low testosterone, a condition called hypogonadism. Now, low testosterone isn't just about libido, though that is affected. We're talking about fatigue that doesn't improve with sleep, brain fog, loss of muscle mass, increased body fat, mood changes, even cardiovascular risk. Testosterone replacement therapy, TRT, is the medical treatment used to bring those levels back to a normal physiologic range. And the options have exploded. Injections, gels, patches, pellets, and oral formulations are all now available. But here's the thing. TRT prescriptions have tripled in the last decade, and with that growth has come a massive wave of misinformation from both sides. Some people swear it's the fountain of youth. Others call it dangerous and unnecessary. The truth, as always, is more nuanced. Let's go through it together. This is where I need to push back on a trend I see constantly. Men self-diagnosing low testosterone based on symptoms alone and either demanding a prescription or buying it online. Here's what proper diagnosis looks like in my clinic. We don't just run one blood test. We run at least 2 fasting morning testosterone panels because testosterone fluctuates throughout the day, peaking in the early hours. We check total testosterone, free testosterone, LH, FSH, prolactin, and thyroid function because all of these overlap in their symptoms. True hypogonadism is defined as total testosterone below 300 nanograms per deciliter, combined with clinical symptoms. Both boxes need to be checked. What I often find in practice is that men who feel awful have testosterone levels in the low normal range, say 350 to 450, and the actual culprits are poor sleep, metabolic syndrome, or thyroid dysfunction. Treating those conditions first, without TRT, often resolves every single symptom. So before you ask for testosterone, rule everything else out. A good urologist or endocrinologist will insist on this. Let's talk about what TRT genuinely, evidence-based does when it's appropriately prescribed. First, energy and mood. Multiple randomized controlled trials show significant improvements in fatigue scores and depressive symptoms in men with confirmed hypogonadism after 12 weeks of TRT. This is real. The effect is clinically meaningful. Second, body composition. TRT increases lean muscle mass and reduces visceral fat, the dangerous fat stored around your organs. One landmark study showed an average loss of 3 kilograms of fat mass over 6 months in hypogonadal men on TRT, even without a major change in diet or exercise. Third, bone density. Testosterone plays a major role in maintaining bone mineral density. Men with chronically low testosterone are at significantly elevated risk of osteoporosis. TRT has been shown to meaningfully increase bone density, particularly in the lumbar spine and hip. Fourth, sexual function. This is the one everyone asks about. Yes, TRT improves libido and can help with erectile dysfunction. But here's the important nuance. If your erectile dysfunction is primarily vascular, meaning poor blood flow, testosterone won't fix it. That's a separate problem needing separate treatment. Fifth, cardiovascular health. And this one surprises people. After years of concern that TRT raised heart attack risk, concern that was based on a flawed 2010 study that was actually retracted, the data has swung the other way. The TRAVERSE trial, the largest randomized trial on TRT and cardiovascular outcomes to date, found no increased risk of major cardiac events in men with hypogonadism on TRT. Now, here is the section that the men's health clinics that just want to sell you a subscription don't spend enough time on. Risk number 1, fertility. This is the big one. When you introduce exogenous testosterone, meaning testosterone from outside your body, your brain detects it and sends a signal to your testes to stop producing their own. LH and FSH drop. Sperm production drops dramatically. I have seen men go from normal sperm counts to near zero within 3 months of starting TRT. If you are not done having children, you need to have a serious conversation about fertility preservation, including sperm banking, before you start. Not after, before. Risk number 2, polycythemia. Testosterone stimulates your bone marrow to produce more red blood cells. This sounds fine until your hematocrit climbs above 54%, at which point your blood becomes dangerously thick and your stroke and clot risk skyrockets. This is why regular blood monitoring is non-negotiable on TRT, every 3 to 6 months, no exceptions. Risk number 3, testicular atrophy. Because your testes are no longer being signaled to produce testosterone, they shrink. This is reversible in most cases when TRT is stopped, but it does happen, and patients deserve to know. Risk number 4, sleep apnea. Testosterone can worsen or unmask sleep apnea. If you snore, if you're overweight, or if your partner says you stop breathing at night, get a sleep study before starting TRT. Undiagnosed sleep apnea on TRT is a dangerous combination. Risk number 5, estrogen conversion. Testosterone converts to estrogen via an enzyme called aromatase. In some men, this conversion is excessive, leading to breast tissue growth called gynecomastia and mood swings. Aromatase inhibitors can be used to manage this, but they require careful monitoring and shouldn't be used indiscriminately. Not all TRT is the same. The delivery method significantly affects how stable your levels are, how you feel, and what side effects you're exposed to. Intramuscular injections, the traditional weekly or biweekly shot, cause peaks and troughs. Some men feel great right after the injection and terrible by day 12. Subcutaneous injections in smaller, more frequent doses smooth this out considerably. Topical gels are convenient, but carry a real transfer risk, meaning if your partner or a child touches the application area, they absorb testosterone. This is particularly dangerous for pregnant women and children. Pellets, implanted under the skin every 4 to 6 months, provide the most stable levels, but are not adjustable once implanted, a problem if you have side effects or need to change your dose. Oral testosterone undecanoate is the newest FDA-approved oral option. It's promising for men who can't do injections, but it requires twice-daily dosing with fatty meals for proper absorption and is the most expensive option. Work with your physician to find the delivery method that fits your life, because compliance drives outcomes. Remember at the start when I said there was something almost nobody talks about? This is it. Most men who start TRT stay on it for life, and for men with primary hypogonadism, where the testes themselves are the problem, that may be the right call. But for men with secondary hypogonadism, where the signal from the brain is the issue, there is a legitimate path to stopping TRT and restoring your natural testosterone production. It's called a PCT protocol, post-cycle therapy, and it involves medications like clomiphene or HCG to restart the HPG axis, the hormonal communication loop between your hypothalamus, your pituitary, and your testes. The problem is that many men are never told this option exists. They're started on TRT with no discussion of what stopping looks like. And when they want to come off, maybe they want to have children, maybe they don't want to be on medication forever, they're told it's just not possible. That's not true for everyone, but it requires a physician who actually understands reproductive endocrinology. Which brings me to my next point. If you walk into a low-T clinic and they hand you a prescription after a 15-minute consultation and a single blood draw, walk out. You deserve better than that. Here is exactly what I want you to do if you're considering TRT, or if you're already on it and wondering if you're being managed properly. Question 1. Have I had at least 2 fasting morning testosterone measurements, at least a week apart? Question 2. Have we ruled out secondary causes, thyroid, sleep apnea, metabolic syndrome, medication side effects? Question 3. Have we discussed fertility and, if appropriate, done sperm banking? Question 4. What monitoring schedule are we on, and what are the exact thresholds that would prompt us to adjust or stop? Question 5. What is the plan if I want to come off TRT at some point? Is restoration of natural production possible in my case? If your doctor can't answer these questions clearly and confidently, you may need a second opinion from a urologist or reproductive endocrinologist who subspecializes in male hormonal health. TRT is not a villain. It's not a magic bullet either. When it's appropriately prescribed, properly monitored, and understood by both the patient and the physician, it can genuinely transform quality of life for men who need it. What I want you to take from this video is not fear and not hype. I want you to walk into your next doctor's appointment informed, asking the right questions, and refusing to accept a prescription that doesn't come with a real plan. If you found this video useful, please share it with someone who's been wondering about TRT. It could genuinely help them. Drop a comment below with your biggest question about testosterone. I read every single one, and I build future videos directly from what you ask. Subscribe if you want clinical-grade information without the internet hype. I post every week, and I'll see you in the next one.